Hello, everyone, and welcome to our module on pharmacokinetics. In an ideal world, if you gave, say, 50 milligrams of a drug, it would go directly to the target organ and exert its effect. But as you can imagine, that's not the case, and that's because a number of different processes affect the ability of the drug to achieve its desired result. And these include things like absorption of the drug from the GI tract and distribution of the drug throughout the body, metabolism by organs like the liver, and then, of course, excretion. All of these things impact the drug's ability to achieve the desired result. So pharmacokinetics is the study of how drugs move through the body, and that's what we're going to talk about in this module, and it includes most of these things I've listed right here. So first, let me just review some of the terms we use for the different routes of administration of drugs. When we say a drug is administered enterally, we mean it's administered using the GI tract. Now, usually this means oral, but sometimes it can be sublingual, which is under the tongue, and rarely it can mean rectal administration. When we say something is administered parenterally, we technically mean it does not use the GI tract. And usually when we say parenteral administration, we mean IV, IM, or sub-Q. So this would be intravenously, intramuscularly, like an injection in the thigh, or subcutaneously, which means under the skin. Now, technically, there are other forms of parenteral administration that don't use the GI tract besides these three I've written here, but they're usually referred to by their own names. So these are names like inhalation for things like asthma drugs. Some drugs are administered intranasally. Sometimes, very rarely, we administer drugs directly into the spinal canal. That's called intrathecal administration. Of course, there are topical drugs which are absorbed by the skin. So the method by which you administer the drug affects how much of it will be available to the body. And we describe the amount of drug that's available to the body as the bioavailability, which is usually abbreviated with the letter F. So the bioavailability is the percent of the drug that reaches the systemic circulation unchanged from its initial form. So suppose you gave 100 milligrams of a drug orally, but after absorption and metabolism, only 50% reached the bloodstream unchanged, then you would say the bioavailability of that drug is 50%. And this gives us an indication of how much the drug gets altered as it moves its way into the circulation from whatever route you chose to administer it. So it's high yield to know that when you administer a drug intravenously, the bioavailability is 100%. You're injecting the drug directly into the systemic circulation, and therefore the entire dose is available to the body. It's also high yield to know that when you administer a drug orally, the bioavailability is always less than 100%. And that's for two reasons. First, every drug has some degree of incomplete absorption, and there's also something called first-pass metabolism by the liver. So let's talk about first-pass metabolism. So oral drugs that get absorbed go directly to the liver, and some drugs are very rapidly metabolized such that on the first pass, a significant portion of the drug is eliminated before any of the drug gets to the systemic circulation. So this first-pass metabolism can decrease the amount of drug that reaches the systemic circulation. And one caveat about this that's high yield to know is that in patients with liver disease, the amount of first-pass metabolism can fall. This means more of the drug may reach the systemic circulation than you would ordinarily expect. There is a way to experimentally determine the bioavailability of drug, and you should be familiar with this technique for your boards. So the way you do this is you plot the plasma concentration over time for both an IV and oral dose. So first, we're going to administer an IV dose here at time 0, and what's going to happen, as you can imagine, is the plasma concentration will shoot up very high, and then it will steadily start to fall as the drug is metabolized and eliminated. Then we're going to repeat the experiment and administer the drug orally at time 0. And what you see when you administer it orally is you see a slow rise in the plasma concentration as the drug gets absorbed. And the rise is generally not as high as the IV drug because some of it doesn't get into the bloodstream, both from absorption and metabolism. And then over time, the drug concentration falls. If you take the area under the curve for the oral administration, like I'm drawing with these lines here, and you compare it to the area under the curve for the IV administration, like what I'm drawing right here, you can determine the bioavailability. So the equation is the bioavailability equals the area under the curve oral, which is generally the smaller number, divided by the area under the curve IV, which is the bigger number, times 100. And this will give you something for the bioavailability like 50% or 60% or 20%. It'll be different for different drugs. So bioavailability was one important concept under pharmacokinetics. And now we're going to talk about a second one, and that's called the volume of distribution of a drug, usually abbreviated V sub D. This is the theoretical volume that a drug occupies inside the body, and is determined by injecting a known dose of the drug and then measuring the concentration that's achieved in the bloodstream. So to understand how we determine the volume of distribution, let's do a little thought experiment on how we could determine a fluid volume in general. I want you to imagine that we took 1 gram of a known substance and we put it into a liter of fluid. Well, then you can imagine that once that 1 gram equilibrated, we would have a concentration of 1 gram per liter. That should be easy to understand. Now I want you to imagine that we took 1 gram of a known substance and we dissolved it in an unknown volume. And then we had a tool that allowed us to measure the concentration once the gram had equilibrated. And if we found a concentration of 1 gram per liter, we could then back calculate and determine that that unknown volume must have been equal to 1 liter in order to generate this concentration. So if you understand what I just said on the last slide, then you can understand how we calculate the volume of distribution. We inject a known amount into the body, and that's the total amount we've put into the body, and we allow it to equilibrate, and then we measure the plasma concentration, and we simply divide these two numbers. So for example, if we injected 10 grams and we achieved a concentration in the bloodstream of 0.5 grams per liter, the volume of distribution of that 10 grams for that drug must be 20 liters. And the two numbers for this equation are very easy to get. We know the amount injected because we have control over that, and then we simply take a blood sample once equilibrium has been reached, and we can measure the plasma concentration. Now, it's a little more complicated than I just described to actually do this on a real patient, and that's because the drug is being steadily eliminated over time. So it's hard to determine what that steady state concentration is to use in the calculation of volume of distribution when the concentration is constantly changing. So to understand how we actually do this clinically, let's take a look at the chart I've drawn on this slide here. So I've put time along the x-axis like this, and the plasma concentration of the drug along the y-axis like this. And what I want you to imagine is that we inject a known quantity of drug right here at time 0. Well, what will happen is that the concentration will shoot up to some very high level, but then it will begin to fall. Now, initially, it falls at a relatively steep slope, and the reason this occurs is because the drug is distributing throughout the body. We've injected into the bloodstream, but it's moving in and out of tissues and finding its steady state concentration in the body. But once it's distributed, the slope of the decrease starts to shift, and now we see a steady decline like this as the drug is being eliminated from the body. Well, mathematically, we can extrapolate this line back to the y-axis and find this C sub 0 point right here. And this is the concentration that would have occurred if the drug had immediately distributed throughout the body. In other words, if we had injected it at time 0, like I've shown right here, and there was no time required for distribution, it immediately distributed to all the tissues in the body. If that had happened, we would have achieved this concentration, C sub 0, right after we injected. And so we take that number from this chart, and we use that in the denominator of the volume of distribution calculation. Then on top, we put the amount injected. And this is the way we can clinically measure the volume of distribution, taking into account the fact that the drug concentration is changing as it's being eliminated from the body. The reason the volume of distribution is such an important concept is because it's very useful for determining dosages. For example, imagine you knew that the effective concentration of a drug in the plasma was 10 milligrams per liter. Well, if you knew that the volume of distribution for that particular drug was 10 liters, then we could calculate the dose we need to give the patient. That dose would be 10 milligrams per liter times 10 liters, or 100 milligrams. So once you know the volume of distribution, you can then calculate the dose you need to give the patient to achieve the desired concentration of the drug. The volume of distribution tells us something about which fluid compartments in the body a drug likes to distribute to. So recall from the modules on renal physiology that I said about 60% of our body weight is water. So for a 60 kilogram person, that's about 36 liters of water. Now that's split up 1/3, 2/3, such that 1/3 of that volume is extracellular and 2/3 is intracellular. For that extracellular fluid volume, 1/4 of it, or about 3 liters, is in the plasma, and the remainder, or about 9 liters, is interstitial. So the volume of distribution of a drug is going to increase when a drug distributes to more fluid compartments and thus occupies more of these volumes of fluid inside the body. So drugs that are restricted to the vascular compartment often have a relatively small volume of distribution. These drugs are usually large charged molecules that have trouble leaving the vascular compartment. Often they're protein bound, and by being bound to proteins in the bloodstream, this holds them in the vascular compartment. And warfarin is an example of a drug like this, which has a volume of distribution of 9.8, which is relatively small. On the other end of the spectrum are drugs that accumulate in tissues. These drugs can have enormous volumes of distribution. These are usually small lipophilic molecules that easily leave the bloodstream and go into tissues. They often have an uneven distribution in the body, so they're not distributed equally. And chloroquine is an example of a drug like this. It has a volume of distribution of 13,000 liters. Now, there aren't 13,000 liters of fluid in the entire body. So, how does this happen? Well, the reason is because the drug is accumulating in the tissues. There's a large amount of it stored in the tissues and just a little bit of it getting into the bloodstream. This means that when you calculate the volume of distribution, you get a very large number. Recall that volume of distribution is a ratio. On top, you put the known amount that you inject into the patient, and on the bottom, you put the concentration in the plasma. Well, if you inject a huge amount, but it all goes to the tissues, you will have a very small amount in the plasma, and this will make the volume of distribution extremely large. And that's why it's important for you to remember that volume of distribution is a theoretical volume that the drug would fill, not an actual volume. And the reason that's important is because drugs can have a volume of distribution that's bigger than all the fluid in the body. And the reason is because that is a theoretical volume, not a true volume. Many drugs bind to plasma proteins, and the protein that they usually bind to is albumin. And this can hold them largely in the vascular space. It won't entirely hold them in the vascular space because some of the drug will not be bound. But the more of it that is bound, the more that gets hung up in the vascular space. And this is a feature that can lower the volume of distribution for a drug. A clinical correlation of this fact occurs in the setting of hypoalbuminemia. Patients who have liver disease can underproduce albumin. Patients with a nephrotic syndrome can lose albumin in the urine. In both of these situations, hypoalbuminemia can develop, and this means there will be less plasma protein binding of drugs. This means there will be more unbound or free drug present in the body, and this can move to the peripheral compartments, and that will raise the volume of distribution. This can potentially alter the required dose of a drug through a couple of mechanisms. First of all, when there is more free drug, it can more easily move to the peripheral tissues. This can generate greater effects and also greater side effects. In addition, when there is more free or unbound drug, it can be metabolized and excreted faster, and this can also alter the dose that's required of a drug to achieve a given effect. Now let's talk about the concept of clearance of a drug from the body. And in order to understand this, let's draw a picture. So let's imagine that we have a tube and it contains 1 liter of plasma. So I'm going to write the number 1 liter down here at the bottom. Now let's imagine that we put 5 grams of a drug into this liter of plasma. So I'm going to draw 5 circles here, and each circle represents a gram of a drug inside that liter of plasma. Well, you can easily imagine that the concentration of the drug inside this liter must be 5 grams per liter. Now I want you to imagine that the kidneys excrete 5 grams from the body. So they take 5 grams out of this liter of plasma and remove it from the body. Well, it's very easy to imagine 5 grams of the drug being removed, but what's harder to conceptualize in your head is the fact that the kidneys have therefore cleared 1 liter of the drug by removing those 5 grams. Now we know it's 1 liter because I told you it was 1 liter at the beginning of this exercise, but if we didn't know it was 1 liter, we could easily calculate that. We would take the 5 grams which were removed from the body and divide by the concentration of 5 grams per liter, and this would give us a clearance of 1 liter. So the amount removed by the kidneys divided by the concentration in the plasma will give you the clearance, and that represents the volume that held the amount of the drug that was cleared by the body. So back to our slide, clearance represents the volume of blood cleared of a drug. It's the volume of blood that contained the amount of drug that the kidneys removed. It's a number in liters per minute or volume flow that the kidneys are clearing, and we can calculate it by taking the excretion rate, for example, 5 grams per minute, if that were the excretion rate of a drug, and then dividing it by the plasma concentration. For example, if the plasma concentration were 5 grams per liter, we could put that on the bottom, and then we divide these two numbers, and we would get a clearance rate of 1 liter per minute for drug X by the kidneys. Clearance of drugs mostly occurs via the liver or the kidneys. The liver clears drugs in 2 ways. It can biotransform the drug into metabolites, and I talk about this in one of the other modules. It also can excrete drugs directly into the bile, and then they go out in the GI tract stool. And then the kidneys can clear a drug by secreting it or filtering it and excreting the drug into the urine. If you know that the liver and kidneys clear drugs from the body, then it's easy to imagine that in liver or kidney disease, the clearance rate may fall. This means that the concentration of the drug in the plasma may rise, and sometimes toxicity can occur. And many drugs need to have their dosages adjusted in patients who have kidney or liver disease. You can also calculate the clearance if you know the volume of distribution, but in order to do this, you need to know something about the drug called the elimination constant, K sub E, and the elimination constant represents how quickly the kidneys clear a volume of plasma of the drug. So if you know that constant, then the clearance of drug X will be equal to the volume of distribution times the elimination constant. Now, this equation sometimes confuses students because it implies that the larger your volume of distribution, the more the kidneys clear the drug. And that should make sense to you if you think about what the volume of distribution means. So let's imagine that we've got our tube again with 1 liter of plasma inside it. And let's imagine that that 1 liter represents the volume of distribution of drug A. So I'm going to label this drug A. So we put 5 grams of drug A into that 1 liter, and it distributes throughout the 1 liter because that's its volume of distribution. Now I want you to imagine that the kidneys clear 5 grams a minute by excreting the drug in the urine. Well, that 5 grams will get removed, and the clearance of drug A will thus be 1 liter. Now let's imagine we have drug B. So I'm going to write a B up here, but let's imagine that drug B has a volume of distribution of 10 liters instead of 1 liter. So I'm going to fill this tube with 10 liters of plasma. Now I'm going to put 5 grams of drug B inside. So once again, we've got 5 circles representing the 5 grams of drug B. Now the kidneys excrete drug B the same way they do drug A, so they're going to remove these 5 grams. But the clearance for drug B is going to be much greater. By removing 5 grams of drug B, you've just cleared 10 liters of fluid because its volume of distribution is so much higher. When you removed 5 grams of drug A, you only cleared 1 liter of fluid. So going back to our slide, this is why when the volume of distribution goes up, the clearance goes up. Remember, the clearance is not the amount of the drug being removed by the kidneys. It's the volume that held that amount of drug. It's the volume of plasma that has been cleared of the drug. So the higher the volume of distribution, the more plasma that gets cleared when the kidneys remove a certain number of grams. So I've summarized that for you up here. The higher the volume of distribution, the higher of clearance. And suppose 10 grams an hour is removed from the body. If you have a higher volume of distribution for the drug, there's a higher volume holding that 10 grams, and therefore you have a higher clearance per unit time. One of the reasons this equation can be confusing is because it's often illustrated as an equation to calculate the clearance from the volume of distribution and the elimination constant, but that's really not how it's usually used. It's usually used to calculate an elimination constant, K sub E, for different drugs. So if you think about it that way, then the elimination constant is equal to the clearance divided by the volume of distribution. And this makes a lot more sense intuitively. The higher your clearance, the higher your elimination constant. Conversely, the lower your clearance, the lower your elimination constant. And then if you've got a large volume of distribution, this is going to shrink or decrease the magnitude of the elimination constant. So from my perspective, this makes a lot more sense. And this is the way it's usually used in the pharmacology literature to calculate elimination constants for different drugs so that you can compare one to another. You can also determine the clearance of a drug by monitoring its plasma concentration over time as it's excreted from the body. Let's look at this figure on the slide. Imagine that we administer a drug at time 0. What we would see is that the plasma concentration would begin to rise, then it would peak, and then it would begin to fall as the drug is excreted from the body, and eventually it would fall to 0. You can use the area under the curve, which can be determined mathematically, to calculate the clearance. If you take the dose that was initially administered and divide by the area under the curve, you will get an answer that has units of liters per minute, and that answer will be the clearance of that drug body. Now let's talk about half-life. So the half-life of a drug is the time required to change the amount of drug in the body by 1/2. And it's usually determined by calculating the time required for the concentration of the drug to fall by 50%. And the half-life depends on the volume of distribution and the clearance of the drug. You can imagine that drugs with a very large volume of distribution take a long time for their levels to fall. You can also imagine that drugs that have a very high clearance rate fall more quickly than drugs that have a slow clearance rate. So the equation for half-life is that the half-life is equal to 0.7 times the volume of distribution divided by the clearance. So let's talk about what's going on inside the body after each half-life. Let's imagine that at time 0, we have 100% of the drug inside the body. Well, once one half-life goes by, the amount in the body will have fallen by 50%. So now we have 50% remaining in the body. After 2 half-lives, we're down to 25%. After 3, we're down to 12.5. After 4, we're down to 6.25, and then it starts to get even lower. Now, it turns out that once the amount remaining in the body falls below 6.25%, most drugs don't have any more therapeutic effects. So we generally say it takes 4 half-lives to get the drug out of the body, which means it takes 4 half-lives for it to fall to such a low level that it's not going to have any clinical impact for the patient. So the half-life has a very important role to play in the amount of time it takes for a drug concentration to reach steady state inside a patient. And it's very important that you understand this concept. So let's review this chart I've drawn on the screen, which is a fairly classic pharmacology chart. So in this chart, we have the number of half-lives of the drug along the x-axis, and we have the amount of drug or the dose that we've administered to the patient on the y-axis. So let's imagine that at time 0, we give the patient a dose of 10 milligrams. And then we let one half-life go by. Well, the amount that's inside the patient is going to fall from 10 to 5 after one half-life. That's a 50% drop. But now let's imagine we give another 10 milligram dose. Well, this is going to pump the amount of drug in the patient up to 15 milligrams. When another half-life goes by, we're going to fall down to 7.5 milligrams right here. But then we give another 10 milligram dose and we go up to 17.5 milligrams right here. After another half-life, we fall to half of 17.5, which is 8.75. But now we give another 10 milligrams and we go up to 18.75. After one more half-life, we now fall to 9.4, which is half of 18.75. And now we give another dose and we go up almost to 20. And now what's going to happen after we pass 4 half-lives is we're basically going to go up and down from 20 down to 10, up to 20, down to 10, and up to 20. So what you can see is that somewhere between 4 and 5 half-lives, we reach steady state such that the dose is going up and down between the same two numbers. So it's very important you understand this chart, and it's very important that you understand that it takes 4 to 5 half-lives in order to reach steady state when you're giving a repeated dose of the same amount to a patient over time. Now let's talk about how you calculate dosages of medications using things about the medicines like their volume of distribution and their half-life. The first thing you need to know is that there are 2 types of dosages we talk about. The first is called the maintenance dose, and that's a dose that's just enough to replace what was eliminated. In the example I just showed you on half-lives, that would be the 10 milligrams. And we want to get to steady state where we're replacing the 10 milligrams that gets lost with each half-life. A second type of dose that's sometimes administered is called a loading dose. And this is given when the time to steady state is very high. You'll give a very large dose for the first dose to get the concentration in the body up very high, and this will get you to steady state more quickly. And this is something you can do when the half-life is very high for a drug. It's high yield to know what happens to the maintenance and loading dosages in kidney and liver disease when the clearance of a drug may change. So in kidney or liver disease, the maintenance dose may fall. What's happening is that the body is eliminating less of the drug per unit time, so less needs to be replaced. But it's very important to know that the loading dose doesn't change. The loading dose is just to get you to steady state more quickly, so you won't give a different loading dose in patients with kidney or liver disease, but the maintenance dose will be affected. So if you want to calculate the maintenance dose for a drug, you want to set that dose equal to the elimination rate. And the elimination rate is going to be the desired concentration of the drug for therapeutic effect times the clearance. So for example, if we wanted a concentration in the body of 5 grams per liter, and we knew that the clearance of the drug was 5 liters per minute, we would just multiply these two numbers by each other, and we would get that we need a dose rate of 25 grams per minute to maintain this level of 5 grams per liter inside the body. And this is the dose required to match the elimination rate. Now, one caveat to what I just said on the last slide is if the bioavailability is less than 100%, then we need to increase the dose to account for this. So for example, in the last slide, we calculated a target dose that matched the elimination rate. But if the bioavailability were less than 100%, we'd have to divide that target dose by the bioavailability F to get the appropriate oral dose. This is easier to understand if we use some numbers. So imagine we had a target dose of 25 grams per minute to match the elimination rate like what I showed you on the last slide. However, imagine the bioavailability is only 50% when the drug's administered orally. This means we need to increase this number by 50% to make up for the amount that gets lost through first-pass metabolism or poor absorption. So the correct dose rate would be the 25 grams per minute divided by the bioavailability 0.5 or 50 grams per minute. So we're giving more dose than we actually want because we know a lot of it is not going to make it into the circulation, but this will ensure that the proper amount gets into the circulation to create therapeutic effect. Now let's talk about a loading dose. So the goal of a loading dose is to get you to steady state right away instead of having to wait 4 to 5 half-lives like I showed you a few slides ago. So in order to calculate a loading dose, you take the target concentration you want to achieve and you multiply by the volume of distribution of the drug. So suppose, for example, we wanted a concentration of 5 grams per liter because we know that that creates a therapeutic effect. If we also know the volume of distribution of the drug is 10 liters, then we can figure out our loading dose. We take the 5 grams per liter that we want times the 10 liter volume of distribution, and this tells us that we need to give a 50 gram loading dose. And the goal of this dose is to get us up to that concentration of 5 grams per liter immediately without having to wait several half-lives. Now, once again, if the bioavailability is less than 100%, you need to divide by F to increase the dose and account for the amount that's lost by poor absorption or first pass metabolism. So this gives an equation for the loading dose of loading dose is equal to the desired concentration of the drug times the volume of distribution divided by the bioavailability F. So here's our chart of time to steady state again, where I showed you that it takes between 4 and 5 half-lives to get to a point where our maintenance dose is taking us from 10 up to 20, and then we go back down to 10 and back up to 20. The goal of a loading dose is to immediately shoot you up to 20 grams inside the body. Then that will fall down to 10 with 1 half-life, and then you can give the maintenance dose. But the point is you will achieve steady state right away after 1 dose instead of having to wait 4 to 5 half-lives. Drugs that have a half-life of, say, several days often need a loading dose so you get up there quickly. Drugs that have a half-life of just a few hours, you can often just give the maintenance dose and the patient will quickly be up to steady state. Depends on how quickly you need to get to the therapeutic effect. So we talked about a number of things in this module. Let me just leave you with a couple of key points that are very high yield to remember. The first is that the volume of distribution can be determined by the amount you inject divided by the concentration of drug that you achieve. The clearance equation is very important, 0.7 times the volume of distribution over the half-life. Remember that you need 4 to 5 half-lives to get to steady state if you're giving the maintenance dose only. And you should know the equations for the maintenance dose and for calculating the loading dose based on the desired steady state concentration, the volume of distribution, the clearance, and the bioavailability. And that concludes our module on pharmacokinetics.